Hi, my name is Jared Dixon, and today I'll be discussing a sporting injury known as acetabulum labral tears. I'll be going through the anatomy and function of the labrum within the hip, as well as discussing the causes, the biomechanics and forces acting on the hip, and the populations affected. I'll also be going through treatment methods, as well as effective rehabilitation techniques. With regards to the anatomy and function of the hip, I'm going to answer that with a visual aid. Here is a hip I prepared earlier. So, while we can't see many of the internal structures, the labrum, which we'll be focusing on, we will have an idea of what it will do. So, with the labrum of the acetabular joint, what it does, it's a fibrocartilaginous rim inside, which effectively deepens the socket and encompasses the circumference of the acetabular socket. So it's made of a tough kind of cartilage, as it has to go through a lot of movements. The labrum is imperative to overall hip health and function, so it allows for gliding movements such as through flexion, extension, internal and external rotation. So more specifically, the labrum of the hip allows the thigh to rotate in every direction through flexion, extension, internal and external rotation. Additionally, the labrum aids in proper alignment of the hip, so the head of the femur into the acetabular socket, and can prevent dislocations. It also helps encase the joint fluid known as synovial fluid, which reduces stress and friction and allows for smooth movement between the ball and the socket. So in essence, the labrum is a ring of cartilage that provides support and flexibility to the joint. So obviously when this becomes damaged, as through a tear, it limits mobility, flexibility and overall movement within the hip joint. So there are classifications for acetabulum labral tears. The first stage, which is known as stage 0, is when there is no tear present, however there is a contusion to the labrum, and it can also lead to synovitis, which is inflammation of the synovial membrane within the hip. Stage 1 is when there's a slight discrete tear, and the articular cartilage of the joint and the cartilage surrounding the femoral head is remaining intact, however. Stage 2 is where there is a tear in the cartilage as well as the labrum, and particularly on the femoral head. Stage 3 can be subcategorized into stage 3A and 3B. Now 3A is when the damage to the labrum is less than 1 centimetre of a tear, and 3B is when there is greater than 1 centimetre tear. Stage 4 is known as when there is extensive tearing, extensive damage to the acetabular labrum, and this is commonly associated with arthritic changes within the joint. With regards to hip dysplasia, there are different types of impingements that can occur as a result of it, the first of which being the cam impingement, in which there is a bony process located on the femoral head which can prevent movements such as abduction particularly. The next is known as the pincer impingement, in which the bony process is located on the acetabular socket, preventing further adduction of the hip. And both the cam and pincer processes combined can restrict movement and mobility within the hip altogether. So in most cases of an acetabular labral tear, you'll present no kind of symptoms. However, when they do, it's usually in the form of pain, which is the most prevalent, as well as kind of a catching, kind of locking sensation felt in the hip, as well as stiffness in range of motion. Now, the different ranges of motion we'll go through later in this video. Acetabulum labral tears are most commonly associated with sports that involve lots of stopping movements, such as football, rugby, and tennis, as well as sports which incorporate more extreme movements, such as rowing and martial arts. Structural defects are also known to be an indicative factor, such as a shallow acetabular socket, which is commonly found within gymnasts, as there is a lot of trauma or overuse. It's also a common finding within the ageing population in an ageing hip, where the degeneration process is occurring, and that labral tears can occur as part of that. Acetabular labral tears have also been associated with posterior hip dislocations as well as acetabular dysplasia. Acetabulum labral tears are mostly a joint issue. The most effective way of diagnosing this would be to go through passive ranges of motion throughout the hip. The first of which will be flexion, in which we want the knee bent and we'll just passively flex the hip. The femoral head is articulating across the posterior acetabular aspect of the acetabulum socket, and if there's pain present here, it is indicative of where the terminal labrum is. Additionally, we can also take the patient through passive adduction of the hip as well as abduction. Again, looking for any kind of locking, looking at any kind of painful sensation. If we just get the client to roll onto their front fully. In the anterior aspect of the acetabulum joint, labrum is still apparent, so what we could do is take the patient through passive hip extension, like so. When it comes to diagnosing acetabulum labral tears, there are a few tests we can do. The first of which is the quadrant test, in which the client has the knee on the not used side raised towards their chest, and what we do is we take their other leg, their top leg, hold it around the thigh to get a good stable grasp, then we take it passively through extension and through flexion. Extension would indicate a sacroiliac issue. However, more enduring flexion is when hip pathology such as FAI or acetabular labral tears can occur. It's called the quadrant test, in which we take the patient's leg and we put it into flexion, adduction and internal rotation towards the opposite side shoulder. We push and then we plot along the path staying in flexion. So we'll go there, there, there. And this identifies hip pathologies as well. A positive test would be indicated by pain and apprehension. The other test we could do is the Feder's test, which is flexion, adduction, and internal rotation. What we do is similar to the quadrant test, however this time we start in lateral rotation, abduction, and flexion of the hip, and then we move it straight over into flexion, adduction, and internal rotation. And this is a very key test for diagnosing acetabulum labral tears, as it will be indicated by pain and apprehension, as well as maybe an audible clicking or popping sensation felt in the hip, and that details where the tear in the labrum has occurred. A mobilisation technique we can use is the Maitland's lateral glide on the thigh. So what we do is we clasp around the proximal thigh and we gently go through grades 1 and 2, which is mainly for pain and stiffness. And we apply lateral glide, so we come up relative to the hip. This is important to have the knees flexed at the same time as well. And then for grades 3 and 4, to have the patient roll into their back. So then they have a flexed hip as well as a flexed knee. We take it up into full flexion. We clasp, interlock our fingers around the inner thigh. And we apply lateral glide by I will shift my weight backwards. And here is where we can try and see greater ranges of motion. Another one we can do is the caudal glide, also known as the longitudinal glide, which is also in the Maitland's, which I will prop my knee underneath the client's knee and gently apply a glide longitudinal, so he'll be going to inferior in relation to the rest of the body. And this is good for capsular tightness, trying to increase range of motion. For grades 3 and 4, we generally perform this with the knee flex, so if you have the client roll onto their side, facing that way. In which we take a greater grasp of the knee, and place the hand on the anterior aspect of the thigh and gently pull down through the hip. And we try to experience, the client aims to experience greater ranges of motion. Extreme cases of acetabulum labral tears, the most common form of treatment is to get surgery. However, that's only apparent in extensive cases. In lesser cases, what we can do is we can begin to rehab the condition. The best method for this is to strengthen the muscles surrounding the hip joint, such as with an isometric adductor squeeze. So what we'll have the client do is, while their knees are bent in this position, we'll have them gently squeeze the ball as much as pain and comfort will allow. So you go ahead and squeeze. The next position, we have the patient with their legs fully outstretched, fully extended, and the ball will be placed between their ankles, in which case we'll ask the client to squeeze again. This really targets the adductor group and gets to engage the muscles. And then we have the patient with 90-degree flexion of the hip and in the knee. We place the ball in between the knees and again get the client to squeeze, activating those adductor groups. With these exercises, one of the advantages is they're easily able to be done, so they can be done in any environment. One of the ones we choose to do is a resisted lateral walk with a resisted band. This is a functional exercise that can help to improve and strengthen the hip stabilizers. So what we're asked to do is the patient will have their feet, the hips and knees aligned, approximately shoulder width apart, facing forward, and then we'll ask him to sit down a little bit, and then slowly take the left leg out, and then bring the right leg back in, and again. What's important throughout this movement is that the weight is evenly distributed when both feet are planted on the floor. In order to progress this exercise, in order to really activate those hip stabilizers, what we would do is we'd have him perform the exercise at a lot more increased pace. Another simple exercise we can do is
It's okay, keep going.
Another simple exercise we can do is leg abductions and adductions. And this exercise works well for freeing up the glutes as well as the groin muscles. So what we'll have the patient do is the feet approximately shoulder width apart to begin with. We'll have them bring the leg of the affected hip over into adduction, then a slow control movement into abduction, holding the wall for stability and holding a flat surface. Another exercise we can do is a kick out, which is great for encouraging hip mobility within the joint. So what the patient will do is, leaning against the surface for stability, they will raise their leg into flexion, then slowly into abduction, and reverse the movement, so back into flexion, then down. And you can repeat this on both legs. We will always do bilaterally as to prevent any kind of muscular imbalances. I'd like to take this moment to thank you all for watching my video. I hope I've answered any lingering questions you have regarding femoral acetabulum impingement, and should you have any further inquiries about any other type of musculoskeletal injuries, I'll be happy to answer them in another video. References will be popped down at the end of the video. Thank you all for watching, and see you again soon.